Good evening, sir.
Respected President, sir. Respected President-elect, Dr. Kudwa, sir. The immediate past President, Dr. Madhusudan, sir. The State Secretary, Dr. Prasad, sir. All the office bearers of IMA KSB. And the delegates.
Sir, unmute it.
ವಾಯ್ಸ್ ಏನೋ ಇದಾಗ್ತಾ ಇದೆ.
Sir,
ಸರ್ ಅನ್ಮ್ಯೂಟ್ ಸರ್.
unmute.
So I welcome you all to this webinar, the second webinar of this series. So this is being hosted by the IMA KSB and the academic subcommittee of IMA KSB. And this is an ongoing process, imparting academic knowledge to the members, undergraduates, as well as the postgraduate, as well as the general public. We have been doing this particular program for the past 6 months. To begin with, the tuberculosis awareness program. Then we are coming out with this particular webinar on COVID-19 among children. In the first webinar, we had a wonderful speaker, Dr. H. Paramish and Dr. Vinayak Patel last week. And this week, we have two learned speakers, Dr. Vinod Ratagiri and Dr. Satyanarayan Mysore. Dr. Vinod Ratagiri is a professor of pediatrics from KIMS Hubli, and is also a member of COVID-19 task force. I welcome you, sir, for this particular webinar. I also welcome Dr. Satyanarayan Mysore, the HOD Pulmonology and Sleep Medicine from Manipal Hospital, Bangalore. At this juncture, I request the President-elect, Dr. Kudwa, sir, to give opening remarks. May I request Dr. Kudwa, sir, to give?
Am I audible?
Yeah, you are audible, sir. You are
Yes.
audible.
Respected delegates and the speakers of the day. It is really heartening to know that our academic wing of IMS this year has started with activities with the now series of lectures on COVID-19, which is the need of the hour. And we expect mainly practical points in the management of COVID in future lectures. Anyway, without taking much time, I congratulate the chairman of academic wing, Dr. Harish, and let us go for the lecture proper. Thank you.
The credit also goes to Dr. Karunakar, who is organizing this particular program as well.
Yeah.
May I request Dr. Karunakar, sir, to moderate the program?
Thank you so much. Respected President-elect, sir, President, attend the getting to the link. Somehow there is a signal problem, is not been able to join, but he may join anytime for briefly, and you may have other meeting to go. As Harish has rightly introduced, we are going to stick to the time and do needful topics for the season and the situation of the pandemic. As Kudwa sir is rightly pointed out, keep it in mind to make sure that we invite and consider the topics which are relevant for the current pandemic. The last week we started with two wonderful sessions. We covered pediatric aspect. We covered a wonderful environmental aspect in allergy. And now what we looked at in the last meeting is that though we are focusing on pediatrics, what we decided now maybe one talk in the pediatric, because the third wave we expected to be a pediatric concern. So we are looking at educating members on a pediatric thing. So one talk is going to be on pediatrics. We're also going to have one more talk on the COVID related from the broader specialties, including mainly from medicine and all other specialties. Like today, Dr. Satyanarayana is going to join us. He's going to speak with his experience that we are going to listen to that. All the important topics required for all our members to really get ready themselves to manage the cases in their places will be covered. We also request the members to really message your topics, whichever is interested to Dr. Harish and myself or anyone in the executive committee or office bearers. We really look at those topics also and bring in the experienced speaker to speak on the topic. Now with this, I would like to express. I'm going to invite Vinod Rettigeri. Vinod Rettigeri is a good friend of mine. He's a professor of pediatrics at Kimberley, and he's been a silent worker and has done significant academic activities. And just to introduce you few, he's graduated from All India Institute of Medical Science, Delhi, and he did his training in the diploma in environment health from America. As a professor for quite some time now in the, and he's been one of the pillar of Department of Pediatrics in the Hubli. And now these areas of interest includes respiratory and critical care, childhood tuberculosis, HIV, childhood environmental health issues. And he has more than 60 research papers to himself. He has received awards and he's been the current recognition for him is the member of IAP COVID Task Force of Government of Karnataka. It's been a great honor to him to really contribute, and I'm sure he's making a lot of efforts to really give guidance actually. And Dr. President sir has joined now. Before Dr. Vinod Rettigeri start, we'll request Dr. President to give his remarks. Further, he's been the chairperson of IAP, Indian Academy of Pediatrics, Environmental and Child Health National Chapter. Was the member of Executive Board, National Executive Board twice. He was the president of Karnataka Respiratory Chapter, Intensive Care Chapter. He was the founder member of the environmental chapter of the national and the state level. He was the president of Indian Academy of Pediatrics, Dharwad district branch in 2014. He is the secretary. He was the secretary of National Disaster Management Group and Environmental Child Health Group of Indian Academy of Pediatrics. So this is a brief introduction. He's much more thing. He's been quite actively involved with research. Currently, he's been involved with important research on COVID-related issues in the pediatrics in association with Indian Academy of Pediatrics and the major teams who are investigating various aspects of COVID in the pediatrics. Dr. Vinod, now I request you to just wait for a moment. We will request Dr. Venkatachalapati sir to give brief introduction and then you please take over. Thank you. And may I request Dr. Venkatachalapati to come on the board, please.
Thanks very much, Dr. Karunakar, and I'm extremely sorry. There is a lot of connectivity issue. In fact, I'm traveling, so I've got a lot of connectivity issue. Anyhow, convener Dr. Karunakar for successfully the third wave of COVID. Today, stalwarts in the field and an expert in many areas of pediatric care. So I'm very happy to be part of this program. And second is Dr. Satyanarayana. He is from Mysore. And today we are anticipating the third wave. IMA Karnataka State has taken up this web series to address the third wave of COVID, so that all the doubts and fears would be clarified by our experts. So without wasting much time, I would hand back to Dr. Karnakar to continue the proceedings. Thank you so much.
Thank you, President sir. I also welcome Dr. Lakpur sir, who has just joined now. Welcome, sir. And see,
Thank you, sir. Thank you. Thank you.
Importantly, what we are seeing is that patients are the children COVID positive and going COVID ward is not an issue for us. especially in pediatrics, we know that there is a concern with children becoming asymptomatic, but we are seeing patient coming with something very interesting syndromes after that. So practically, every child who is coming to clinic now, we are looking at. So we know that Rattigiri is going to cover the most important pediatric COVID-related post-COVID issue. Dr. Vinod Rattigiri, it's over to you. Welcome.
Thank you, Dr. Karnakar, sir. Shall I share my screen?
Yes, sir. Go ahead, sir.
Okay. Yeah, is my screen visible?
Visible, sir.
Yeah. Okay. At the outset, I thank IMA Karnataka State Branch for giving me the opportunity to sensitize. I can use the word sensitize for all general practitioners and the practicing pediatrician about this upcoming problem in pediatrics, what we are expecting a surge following the COVID-19. So at the same time, I also thank the office bearers of Karnataka State Branch, including President Dr. Venkatachalapati, Secretary Prasad sir, and Dr. Harish sir, Dr. Karnakar sir, and also all senior members for providing this opportunity. So I will just, without wasting much time, I will straight away go to the topic on multi-system inflammatory syndrome in children. Classically, it is being pronounced as MIS-C. So we all know that in COVID-19, ever since it has affected the whole world. So even in the first wave, we have seen that it is mainly affecting the adults. Even though in the first wave also, the number of children affected are less, but majority of them are asymptomatic. Even during second wave also, we have seen, though the number of children affected are also increased, but still the major chunk is asymptomatic. Almost 90 to 93% was asymptomatic. Another 5% required the hospital admission, and less than 1% children require really ICU care. Now, if you compare that one, this is one syndrome where it is not per se occurring during the acute COVID infection. Majority time we see this event following the COVID events. So that's the most dangerous aspect of this, because we see that most of our children are asymptomatic, but following that many times we are not noticing, and then they will come up with this inflammatory syndrome presenting as fever. And we see that now with the monsoon is coming, now so many causes of fever, and along with this one more added fever. So really we need to identify this syndrome because it is, though we are saying COVID-19 in children is not causing much problem, but this syndrome is really causing a lot of mortality and morbidity if it is not being detected at the early, and if you are not initiating the treatment at the earliest point. That's the reason I have chosen this topic to address all our practicing pediatricians as well as our general practitioners about the multi-system inflammatory syndrome. So in my next 20 to 30 minutes, I just wanted to cover up what is this multi-system inflammatory syndrome in children and why it is important now, and how we need to make a diagnosis, and what are the recent guidelines. I want to just stress the point that it is still an evolving disease. So we need to have still more updates on this one, but I am going to talk on what is today as recent guidelines and up to date to be practiced in our day-to-day practice. That I am going to highlight. So we all know that for diagnosis purpose, we need to have a definition when to call this syndrome. So this is a 5-component which is needed to make a diagnosis of multisystem inflammatory syndrome. The most important one you need to have is the first point, that is fever. It is a must for making a diagnosis. And more importantly, it is duration of fever. At least or more than 3 days duration should be there. Along with that, you should have an involvement of 2 more systems, either a skin, mucous membrane, GI tract, cardiac system, CNS, CVS. Any of these 2 systems should be involved. That has to be there. And the third point, most important, is if you do an investigation in that, as we screen for all these children with COVID, you will have an inflammatory markers which will be raised in that. And most importantly, we are taking CRP as the major investigator or inflammatory marker. If it is raised, or ESR if you take, if it is raised, then we will consider this point. And the fourth one is most important, is there should be a evidence of COVID infection in the form of RT-PCR. Majority time it will be negative. And if you do a serology test, it will be invariably present. That is a must. Exposure history to COVID-19 is a must for making a diagnosis of multisystem. And more importantly, you need to rule out other causes of fever, which is very, very important, because many times other our tropical infection also mimic this condition. So unless you rule out those conditions, then we will consider. So it is basically, we call it as a diagnosis of exclusion. You rule out other tropical condition and then consider the possibility of this. So how do they present? We'll go in detail. So these are the symptoms as I have described. Mainly they will come with the fever because of inflammation. Along with the fever, 2 important organs generally they present is with the cardiac manifestation in the form of cardiogenic shock or myocarditis features, and then skin manifestations like a Kawasaki, they might present with this one. Okay, so these 2 organs are very commonly presenting, and later now we are seeing many children are presenting with other organs also, very specifically the gastrointestinal manifestation and neurological manifestations. These 2 are also now contributing, but unlike in adult COVID, what we are seeing, the respiratory manifestations are less likely in children, or specifically children with multisystem inflammatory syndrome. And they can also present with the vasculitis and endothelial dysfunction. That is the symptoms they can present. So these are the major clinical manifestations they will present with us. So in detail, if you want to go in this one, so they will have a fever, myalgia, conjunctivitis. So that is, along with the fever, you have a skin and mucous membrane involvement. Many times these will mimic like a Kawasaki, which is typically the bilateral conjunctivitis, purulent conjunctivitis, that is typical. Along with that, you have a lymphadenopathy, stomatitis, and sometimes they may present with the extremity swelling, pedal edema, what we call. See, these are features we see in Kawasaki, but all these 5 features may not be there in our multisystem. That's why we typically call it as incomplete Kawasaki syndrome. So along with this fever and skin mucous membrane, they can present with cardiac manifestation in the form of myocarditis, and then hypotension, tachycardia. All these are featured. Later, if you investigate, you may find some amount of coronary aneurysm, which is being seen with the Kawasaki's disease. Similar to that one, we can see if you investigate. The other major organs involved are GI system. They can present with nausea, vomiting, abdominal pain, and also diarrhea. And if you investigate, you may find even liver dysfunction also. Even if child is not having icterus, you may find some dysfunction in the ALT and AST. Along with that, sometimes now we are seeing many children are presenting with the CNS manifestation in the form of encephalitis features, headache. So in this situation also we need to consider. As I told, the respiratory symptoms, unlike in adults, here in pediatrics, especially in MIS-C, it will be less. Even if they are presenting, they may have some amount of fever, cough, respiratory distress. And if you do an investigation, you may find some infiltrates on the X-ray film. And hypoxemia may not be there in these children. The other organs less commonly affected is kidney, which they can present with renal failure and hyponatremia, and the bone marrow, usually thrombocytopenia or lymphopenia, they can have these presentation. But more importantly, what is important here is the inflammatory markers, specifically CRP or ESR. If you do, it will be raised. I will tell you what level we need to consider. The level increase in CRP will be the possibility of MIS-C we can consider in my next slides. And more importantly, as I said, this is a post-infectious disease. So majority time we don't get RT-PCR positive in these children. Even if we find also, it may be in the end stage, may not be in the infective phase. So majority time we get serology positive in these children. Okay, to summarize, to define MIS-C in children, say less than 18 years, fever is a must, that is more than 3 days. Along with that, two important systems, there should be a symptoms either in the form of rash or conjunctivitis, hypotension or shock, or features of cardiac involvement in the form of myocardial dysfunction, or any evidence of coagulopathy. That has to be the, any up to should be there. Along with that, if there is any increase in the inflammatory markers, either in the form of ESR or C-reactive protein, we need to take into consideration. And more importantly, I'm stressing again, the ruling out of tropical infection is most important. You have to rule out all our common tropical infection, including at present, we are having dengue, rickettsia, chikungunya, then leptospira. Sometimes if fever is prolonged one more than 7 days, you need to rule out even the enteric fever also. These are common diseases which can sometimes mimic. So you need to rule out those conditions. Then any evidence of COVID infection in the form of serology positive, or even if you have an exposure history that some family member, if they are affected, then we will take it as significant. So all these 5 points should be there to make a diagnosis of multisystem inflammatory syndrome. I'll just briefly, I'll go into this pathogenesis. I don't want to go in depth. So just I wanted to highlight that it is not the virus which is directly affecting, causing multisystem inflammatory syndrome. It is basically the post-infectious period during which there is an activation of macrophage, which in turn increase or stimulate the T cells. In turn, it will cause a surge in cytokines, which we typically call it as hyperinflammation phase or cytokine storm, which will end up in multi-organ damage. Sometimes this macrophage activation increase the even B cell stimulation, which can produce autoantibodies. Again, they can produce hyperimmune response. This is how the multisystem inflammatory syndrome is caused, not per se directly due to virus infection. So this is again, I wanted to highlight the major pathologies here, endothelial damage, which causes all the problems or all clinical manifestation is due to various organs involved and caused because of endothelial damage. So sometimes we, in clinical practice, we see some children with presenting with only mild disease. Sometimes we see moderate to severe. It's all because of immunological reaction. If there is any early interferon response, rapid viral clearance, usually we get mild disease. If there is any delayed interferon response or slow viral clearance, then we end up with the moderate to severe disease. That's about the pathology or pathogenesis. So what I wanted to highlight here is that during acute COVID cases, we don't see this syndrome, but usually we see after 3 to 6 weeks of peak COVID cases. Now, this is the time we are now ending with the second wave. So we are anticipating in next 1 or 2 weeks, because already 3 to 4 weeks have gone, number of cases with children presenting with MIS-C. This is the period we need to look into that one. And if you do a majority, as I told, the serology will be positive, but RT-PCR will be negative. So the main mechanism here is because of antibody-dependent enhancement of inflammation. So this is the picture graph which has been taken from the UK study, where they have shown typically during COVID peak time, we didn't have MIS-C, but later after 3 weeks, there is a surge of MIS-C cases, and the similar picture is also seen in the first wave in our setup in India also, and now in the second wave also we are seeing in various places, including in my place. We have crossed more than 30 cases of the multisystem inflammatory syndrome, and typically this is the period next, say 2 to 4 weeks, we are expecting a large number of MIS-C cases. So we need to be aware of this condition when we are treating the children with a fever. So what other diseases which can mimic like a MIS-C in pediatrics? So very commonly sepsis, any cause of sepsis, all these features may be there. So we need to rule out that by doing the cultures. And the second one, which I have highlighted, that it is incomplete Kawasaki disease, which I am going to discuss the difference between these two in the next slide. And toxic shock syndrome, again, I'm going to talk that one. But more importantly, what I would like to highlight here point is the common disease, what we are now seeing post-monsoon, during monsoon, is dengue and chikungunya. Majority time they also mimic, but we need to keep our attention that in dengue, you all seen that in the viral phase, fever, myalgia, and bleeding manifestations, which they will come. That typical history will be there, but you don't see the exposure history of COVID may not be there, and IgG may be negative. So those can be differentiating points. And in rickettsia, again, similar to dengue, we have another differential diagnosis, what we are seeing. So again, HR, this clinical manifestation, which is present in many of these rickettsial infection, by looking at that one, we may consider the diagnosis of rickettsial infection. The other two differential diagnoses we may consider is the HLH or macrophage activation syndrome. They will be like a complications of many diseases, specifically the dengue infection. When it goes into severe form, we may anticipate this the lymphocytic activity increase in that one. In those situations, again, inflammatory markers ferritin is one which is increased in these conditions. Again, it is clinical acumen which will help us in making the diagnosis properly. Many times in ICU, we are facing a lot of difficulty in differentiating HLH and the MIS-C cases. But clinical markers as well as the laboratory markers will help us in differentiating these two conditions. So the important differentiation is Kawasaki disease we need to make. Kawasaki is basically seen in children less than 5 years. Very young children are affected more commonly, whereas MIS-C we are seeing even in young children also, but more commonly between 5 to 11 years. The GI symptoms and myocardial symptoms are very common with the MIS-C, but not so with the Kawasaki diseases. And if you see inflammatory markers, very commonly they are elevated in our MIS-C, whereas they are less increased in the Kawasaki diseases. And if you see specifically CBC, the lymphocyte count is elevated in case of Kawasaki disease, but not so with the MIS-C. So evidence of COVID, if you see again in the form of serology or exposure, will be there with the MIS-C, which may not be there in case of Kawasaki disease. This is how we need to make a difference between Kawasaki and MIS-C. The another common disease which we need to differentiate is toxic shock syndrome. Again, this is very common in children about 10 years, whereas as I told, 5 to 11 years is a common age group which is affected by MIS-C. So the cutaneous manifestations are more common with the MIS-C, specifically the Kawasaki features. which may not be there in toxic. They, even if it is there, it is like end stage, like erythroderma, petechiae purpura will be very common. If you see the lymphadenopathy and hemodynamic stability, more so we are seeing these instability in MIS-C cases as compared to toxic shock syndrome. And other systems, as I highlighted, it is cardiovascular system, which is very commonly affected in MIS-C. It is not so with the toxic shock syndrome. So if you do a lab investigation, again, inflammatory markers are the important one, which will be raised in case of MIS-C. Even if it is raised, it is not so high in case of toxic shock syndrome. So this is how we need to differentiate these two conditions. So again, I would like to highlight here for all our friends in the periphery that it is clinical acumen, which is very important. You rule out all tropical infection, including malaria, dengue, chikungunya, rickettsia. You rule out, then you may consider the possibility of MIS-C in our conditions. So if you suspect clinically, if child is having probably MIS-C, what investigation we need to consider? We here made two category. The first one, tier 1, where basic investigations are sent. So including the CRP and ESR. So here, if the count is suggestive, say leukopenia and lymphopenia, and CRP is rise, here we take if CRP is more than 40 as significant indicator of MIS-C. Generally, in all infection, we get increase in CRP, but it is to the extent of maximum 11 to 20. If you have any child more than 40, the possibility of MIS-C you should consider. If you see ESR more than 50, then you may have to consider the possibility of MIS-C. And you may have some amount of derangement of liver, renal, and other things. And more importantly, you need to send the culture because sepsis you need to rule out. So once you have a suspicion here, increased inflammatory markers, then with the clinical features, we have now majority thinking that probably what we are dealing is MIS. Then we need to consider the possibility of doing tier 2 investigations, which are in depth about the inflammatory and coagulopathy markers like ferritin D dimer, then troponin for, which is very specific for cardiac involvement. And more specifically, we are looking into the pro-BNP, which is very specific for the myocardial damage. And then send SARS RT-PCR, but serology is more important. We need to send to find out whether he is being exposed for COVID or not. Then as usual, you need to send the septic screen to rule out the sepsis. Along with that, the imaging, most importantly, we are looking is the echo, which will tell us whether child is having myocarditis or not, and the ultrasound abdomen for looking for other complication. Chest X-ray, if there is any respiratory symptoms, if it is there, then we need to investigate. So these are the few investigations we need to send. And first, we have designated this one, tier 1, where if it is found any evidence, then only we need to go for the tier 2 investigation. So is there any specific parameters we would like to monitor in children when we are suspecting MIS-C? After looking into clinical parameters and lab investigations, how clearly we will make a diagnosis. So important thing in the clinicals is looking at the fever, if it is more than 3 days, high degree fever, cardiac and GI manifestation more common, and skin, especially the features of Kawasaki. We may not have many times neurological, but of late we are seeing these cases also. So if there is evidence, you have to clinically think in terms of more of MIS-C. But along with this, if we have a raised CRP, increased other coagulopathy markers like D dimer and ferritin, we have to consider the possibility of MIS-C in our children. So having been made a diagnosis based on clinical features, those 5 parameters, plus the lab investigations, we need to come to management. So in management, important thing is if it is possible, even if it is a mild case, you need to admit and monitor the child. It is always good. But if it is not possible, at least moderate to severe category patients should be admitted and should be monitored in the hospital. As it is a multidisciplinary care, we need sometimes intensivist, cardiologist, gastroenterologist. We may have to take the help of these people. So it is a multidisciplinary care for the child we need. That's why we need to admit and take care of this one. Along with this, we need to take 2 or 3 important systems which will be commonly presenting. That is the management of shock and management of cardiac dysfunction. So these 2 things we need to take, which I am going to highlight in the next slide. And along with that, whenever we see child with this thing, it is no harm that we can give 1 antibiotics before we could stop or to continue. I think in this situation, when we are in doubt, we can give generally 3rd generation cephalosporins. We can prepare, we can go for that one. Government of India has recommended even amoxiclav also to start with that one. And then we need to give a specific treatment in the form of IVIG or steroids. So in the next slides, I am just going to summarize all these things. So when you suspect a case of MIS-C, the first thing is you need all the clinical features, all 5 components are present, then proceed with the investigation, that is tier 1, which I have highlighted. If that is positive, even investigate with the tier 2. If both are positive, then you consider that it is a case of MIS-C. When you investigate, if there are no features suggestive of MIS-C, even then, when there is a doubtful possibility, do a tier 1 investigation. If it is turned out to be positive again, like increase CRP more than 40, then go for the tier 2. If even when clinically you are not doubtful, then your inflammatory markers are not raised, that means it is negative. So you can work up for the other differential diagnosis. So this is how we need to approach a child with MIS-C. How we manage? I made it very, very simplified. The IAP guidelines, again, taking into consideration various parameters, they tried to help our practitioner. No confusion in this one. It is like a traffic light management, wherein it will start with the green light. Then you have to monitor. If it is yellow, we may have to consider the possibility of treating the child. And if it is red, we have to straight away go for the treatment. So how we have to make, if a suspected child having MIS-C, along with the supportive care, if child is presenting in shock or multi-organ dysfunction, straight away we have to start the specific therapy in the form of IV methylprednisolone. The dose, still there is a controversy, but IAP recommends we can start with 10 milligram per kg. It is for 3 to 5 days we can give. Along with that, we have to give a IV immunoglobulin, that is 2 gram per kg, single dose we need to give. And as I have told, we need to give 1 antibiotic, we need to start. So after 24 to 48 hours, generally we anticipate within 12 to 24 hours, there is a significant improvement in the form fever will come down. If there is any improvement, then we can come down in the dose of methylprednisolone from 10 milligram to 2 milligram per kg. That can be continued for 3 to 5 days. In case if child has not improved over next 48 to 72 hours, we consider that child as treatment failure and then consider the expert advice. So we may consider here the next generation like tocilizumab, infliximab or anacrina, that the other persons will be taken care. If child is having MIS-C but not in shock or multi-organ dysfunction, that we call as KD phenotype, that is Kawasaki phenotype, the classic feature, but not in shock. Then we have to give first IVIG, that is in the 2 gram per kg. Along with that, we need to consider even steroid also, that is methylprednisolone. Remember here, instead of 10 milligram, we are starting 1 to 2 milligram per kg per day, again 3 to 5 days. So there is a dramatic response in most of these children. In case worst come, if it is failed, then instead of giving 2 milligram, we can improve or increase the dose of methylprednisolone to 10 milligram and see for the response. Again, if it is failed, then consider, as I told earlier, the expert opinion and use of other drugs. But what I would like to highlight here, a child with MIS-C suspected not belongs to either short phenotype or Kawasaki phenotype. That is the most common what we encounter in our practice. So this is called with various names. We level as IAP people as mild MIS-C category. Here is our clinical acumen has to be present. We need to monitor the child, admit and monitor. In case if child's fever is not improved over next 48 to 72 hours. But if it is going into, again, either of shock or Kawasaki phenotype, we can manage accordingly if they go into that category. If they don't go into that category, but still fever continue to have, then consider use of methylprednisolone in a dose of 1 to 2 milligram per kg per day and give it over 3 to 5 days. So if majority of time we have seen that these children will improve drastically. In case worst situation, if they fail, then you need to consider the other possibility, rule out alternative diagnosis. So this is a very simplified approach for MIS-C management. So along with that, giving specific therapy in the form of steroid and IVIG, we may have to consider use of other things in the form of the aspirin, if in case you have a coagulopathy evidence. So the dose is here, usually we use 3 to 5 milligram. So maximum of 75 milligram we can use. Only contraindication here is if a child is having platelet count less than 80,000, we should not use. Otherwise, we continue this one for 4 to 6 weeks. The other drug we are considering in severe form of MIS-C is low molecular heparin. Here it is with the specific indication we are not for all children. If you do an echocardiography and ejection fraction is less than 35%, we can consider use of low molecular heparin. That is enoxaparin in the dose of 1 milligram per kg we can use. And duration generally we give 7 to 14 days. Afterwards, you are switching over to aspirin therapy. So this is the treatment we give for MIS-C. And once you give, we need to monitor the children and we need to take out certain drugs. So if child is improving, there is no evidence of infection, stop antibiotic at that point. No need to continue like 3 days, 5 days, no need to continue. The moment we get culture negative or moment we are make sure that it is 100% MIS-C, we can stop antibiotics. And how we have to go for next is monitor the child again using ECG and echo, very important one, which we have to do it after 3 days and see for the ejection fraction. If it is less earlier and after giving IVIG and steroid, definitely there is a improvement that we have to look. And in the long term, after 3 to 5 days, if child is improved, we can plan for a discharge. While discharging, we have to make sure that we have to ask them to come back for follow-up, and during follow-up, we need to evaluate for the cardiac, do a echocardiography at 2 weeks and 6 weeks for any coronary artery aneurysm. So for development of this, we need to evaluate the children. And remember, whatever we have followed up now during first wave and second wave, we have an extremely good outcome in these children, provided we need to make a early diagnosis and start the early treatment. So to summarize, again, stress again in these days where we are seeing large number of children with fever, don't consider, or you can consider, but don't make every case as MIS-C. Please rule out other tropical infection. So MIS-C is a diagnosis of exclusion. Once you rule out all these common infection, we can consider possibility of MIS-C. Once you made a diagnosis, please follow a systemic approach so that outcome will be extremely good. And now if you see the sero surveys, both ICMR have done, now majority of children are also are showing positivity. That means they have been exposed already. So just being IgG is positive doesn't mean that this side is having a MIS-C. So again, we have to put out all the criteria. If it is fitting into that one, then only we need to consider the possibility of MIS-C. Be rational while giving the treatment, either IVIG or the steroid therapy. Okay, so minimum effective doses of steroids should be used to give the better outcome for our children. So again, I highlight that management is a team approach here between pediatrician, intensivist, cardiologist, and gastroenterologist. So we need to take care of everyone. So when you have a doubt, if you are able to manage in your setups, you can manage. But earliest doubt, then you can refer it to a center where it can be managed very well. Thank you. Thank you, one and all. Again, I take this opportunity to thank the IMA Karnataka State Branch for giving me an opportunity to talk on this common topic. Dr. Karnakar sir, if any questions I can take up in this. Sir, unmuted. Karnakar sir. Sir, unmute it. We are not able to hear.
Just a minute, sir.
Yeah, now you are able to do that.
Yes.
Not yet. It's not yet happened. I'll speak through.
Sir,
No.
we can hear you, sir.
It's done.
It's not happening. Let me speak through mobile only, actually. So, Vinod, can you hear me now?
Yes,
Yeah.
sir. Yes, sir. Yes, sir.
Yeah, I think Dr. Vinod has wonderfully covered a most important topic. I'm very happy that you covered various aspects relevant to the topic. One of the important things I would like to bring it at this notice is that this is an evolving disease. Treatment could change. All related issues, including investigation, could modify over a period of time.
Yes.
And one thing I'm looking at now, we talk so much about this disease in our pediatric forums. I'm looking at that the day will come possibly everybody else has to take up the responsibility of managing in the community so that the burden doesn't happen over the referral centers and the intensive care units. Actually, that's an important thing. You want the message to go for all our members. So what we're looking at here is that we would like to really take up every questions, maybe more questions I'm going to ask Vinod from my side rather than everybody else. But I'm more happy to take up questions from each one of you so that we really want to answer this question, because next 6 months to maybe a year, if Corona continues to be an issue, this is going to be an issue for all the our members who are going to see pediatric patient in their clinic actually. So currently already it's come to the extent where in our hospitals, basically every child who comes with fever, we look at possible missing this patient because that's the possibility in the current scenario. We also know that one point I would like to bring it to the attention of all the members, today's Times of India observation or report that happy news, rather 65% of Indian population in most of the places is seropositive. It's a wonderful information to suggest that possibly the risk of third wave may come down significantly. Though pediatric serology appears to be less than that, it's about 57%. I'm really surprised that 57% of children are already exposed to the COVID-19, where the possibility of COVID itself becoming an issue may come down. But one thing is that if about 57% of our children are exposed, the risk of multi-system syndrome, multi-system inflammatory syndrome is going to be a major concern in the days to come actually. So with this, I would like to ask a few questions to Dr. Vinod Redkeri actually. One of the important things that Vinod, you rightly pointed out, maybe you can resend the message to all our members that co-infection is a major issue actually.
Yes.
Right?
Yes.
Yeah.
Yes.
Though we consider it on a priority basis in the pandemic, there have been quite a lot of incidences people have picked up at various sources that it's not exactly the MIS-C, rather. There are many other diagnoses, including rickettsial fever, typhoid fever, burst appendicitis, peritonitis, whatnot. It's like
Yes.
that. Can you put
Yes.
a little more information on that, Dr. Vinod?
Yeah. Sir, what you have brought out is extremely good one. This is the point I would like to share to all our members. Any child coming with fever nowadays is possibility that we have to think that there is no MIS-C but other infection. So as usual, we are earlier treating, similarly investigating the child for malaria if it is acute malaria, enteric fever, dengue fever, chikungunya, rickettsia. All these should be ruled out. Specifically, depending on the area-wise infection, like leptospira is common in certain areas, in certain belts of our Karnataka. So in those areas, you need to rule out these leptospira also. And sepsis, which is very common in our pediatric cases, that has to be ruled out before we need to consider the possibility of MIS-C. So
Thank you.
again,
That's-
I just wanted to stress that we investigate normally and consider possibility of MIS-C if you have ruled out everything.
Yeah, fine. We have another 8 minutes for your session, actually. And
Yes.
Dr. Vinod, I wanted to bring out one more point. You maybe can speak on that. Antibiotic charge. Do we really need to give antibiotics and what to go about?
Yeah, when we are in doubt, it is always better. That's why even Government of India and the IAP has recommended that you need to start the first dose in these children because it is the deterioration in pediatrics is very, very fast. So we can give first dose of antibiotics. So both the groups have recommended you can start with either third generation cephalosporin or the amoxiclav, which can be either of these two, you can use it. And you need to rule out if there is a possibility of infection, we can continue the antibiotics. Wherever facility, you can send the culture, get the report. If not, based on clinical symptoms and lab parameters, whatever available, if there is any doubt, it is always better you can continue the antibiotics. But if you are sure it is now ruled out sepsis, then we can stop at any moment.
Yeah, that's very important. Dr. One point I would like to pass on again with your permission that there is no need to jump to higher antibiotics. Be clear about the epidemiology of disease in your place. Say, for example, if you have a patient with leptospira, you know what antibiotics to give. If you have a patient with the risk of rickettsial fever in your place, you're supposed to use a simple doxycycline. That's as simple as that. Going for meropenem and very complicated top-end medications, it's basically you're draining out the resources of the patient beside inducing antibiotic resistance. That's what I want to clear the message. And as Dr. Vinod rightly pointed out, you need to be careful about co-infection. Dr. Vinod, I want to ask one more question here. There are a few more questions actually.
Yes.
But before taking the chat box, I want to ask one question. Say now, in this COVID pandemic season, now we know that most of the children are exposed, asymptomatic children actually.
Yes.
They are coming with MIS-C actually, right?
Yes.
So what is happening here is one of the important messages I want you to discuss for the benefit of members. If the patient comes with a fever, the two things we are doing in the situation, right? Possibly we do RT-PCR.
Yes.
It's say if negative, it's unlikely to be a case of COVID because any patient fever we have to investigate for COVID also, right?
Yes, sir.
Say if RT-PCR comes negative, but serology comes positive.
Yes, sir.
So here question is that things are happening. There is, as I told, it's really evolving with respect to our understanding and management. Not every serology is a MIS-C actually, right? So
Yes,
now
sir.
I want you to speak about if the patient has got a serology positive, how to go about. It could be MIS-C or it could be something else also.
Yes, sir, definitely. So this is the point I just highlighted in my summary that now the second survey, you have highlighted about the first survey in Times India, which is 57%. Now the second survey yesterday only released from ICMR, which has shown pediatrics involvement is 67.5%. So it is high. So there is already exposure for these children. But just presence of IgG antibodies does not always say that child is having MIS-C. So we need to take into consideration other clinical parameters. Say I said if fever should be there, all 5 components, it has to be there to make a diagnosis of MIS-C. Now, by virtue of this thing, all 5 components are positive. and your serology majority time as it is positive itself. But don't jump into the specific what we have highlighted about steroid or IVIG. We have a category called MIS-C mild. So majority of the time, these children will be in MIS-C mild category, which they will respond within 48 to 72 hours with available antibiotic therapy. Now, if they settle with this, there is no need to go for the steroid therapy or IVIG therapy. That's the point I would like to highlight.
Okay, thank you, Dr. Vinod. I want to bring in one or two more points. As you rightly pointed out in pediatric COVID or MIS-C, practically there is no scope for going for unwanted imaging like MRI. Use X-ray only judiciously. We discussed in the last meeting also. One thing I want to ask you, Vinod, actually, there is a question from the chat box. What about immunization after MIS-C?
Yeah. So this is, as usual, we can start with, this is very commonly asked in every forum. So the moment the impact, whatever MIS-C is settles with the treatment, we can give the vaccination for these children. Unlike other conditions where we can expect that this is like a immunocompromised, we do like to wait for some more days, not like that. So you can give it immediately after everything is settled. So you can start vaccination immediately after once everything is settled. That we have to give.
Say, for example, if it's MIS-C, say in case of MIS-C, we don't need to wait for vaccination, Dr. Vinod, right?
Yes.
But say, for example, child is basically overcomes acute COVID infection actually then.
No, you want to say for acute COVID or
post-COVID? Post-COVID,
yeah,
do we need to wait for vaccination?
See, the government recommendation is you can give a vaccination.
Okay.
Now for pediatric age group, we are not giving at present. But in case if it is available, again, the government has recommended that 3 to 6 months. You can go as early as 6 weeks, but the recommendation is you can give even though these children who are exposed to COVID, whose serology is positive, we can give a vaccination for these children after 3 to 6 months. You have to give it. Don't take it that serology is positive, so no need to give a vaccination. No, like adults, we may have to give vaccination for these children also, COVID vaccine.
Okay. There is another interesting question as we are discussing that you could consider using doxycycline if you suspect rickettsial fever. There is a question in the chat box that one of our respected doctor want to know is it's safe to use doxycycline in children actually.
Yeah, definitely, sir. We have been using this doxycycline ever since we are almost now, I think it is 8 to 10 years, doxycycline, rickettsial infection, we have made diagnosis. So in last 8 to 10 years, we have been used and it is been approved by the FDA also for these children less than 8 years also. So this is specifically for when you are suspecting rickettsial infection. Taking into precaution that we need not, because it is a broad spectrum antibiotics, we should not start using these drugs for many diseases. We may end up with again drug resistance. So it is specifically if you are suspecting rickettsial fever, you can use even for the children less than 18 years. The dose is accurate is say 4.2, but roughly we take 5 milligram per kg per day, 2 divided doses, 5 to 7 days for rickettsial infection we give it.
Okay, there is another relevant question from our members. The time is already 8. We may take another 3 minutes possibly without wasting time for another speaker. There is another question like, what about measles vaccination? They say after giving IVIG or steroid, wait for a few months to give that. They want to know about it. And also say, if you use steroids for more than 15 days, do we need to wait for vaccination or anything else after that?
Okay. So as usual, general standard we have to give. So after say this thing immunosuppressive agent, generally we wait for 8 to 12 weeks. That's the ideal time. After that, we need to give the vaccination. So likewise, even for blood products, when we give, we generally wait for 8 to 12 weeks so that the antibody response will be quite good. Same principle can be applied. Even for steroid, if you are using more than 2 weeks, again, it is a suppressive. You can use vaccination after 8 to 12 weeks. that standard guidelines we need to go over.
Okay, thank you, Dr. Vinod. Maybe
Wait a
sir.
minute, Karnakar. Dr. Suresh Kada raised his hands for a long time.
Yes, sir.
Is he
Yeah.
going to ask some question? Yeah.
Yeah, see, it was an excellent deliberation.
Thank
A
you, sir.
complicated case made very simple, but for the benefit of viewers,
Yes, sir.
management of cardiogenic shock may be
Yes, sir.
explained in few words.
Okay, sir, if it is due to the MIS-C, so we are giving specific one therapy is steroids, which is very important, plus IVIG. Second is if child is in shock, other like inotropes, we may have to use like adrenaline or noradrenaline, depending on the situation. Dopamine nowadays in ICUs, we are not using it. So you can go for adrenaline or noradrenaline. Along with that, dobutamine may be considered depending on the case. Then fluids, it should be again normal fluids we need to use either in the form of DNS or the ringer lactate if child is in shock, either ringer lactate or normal saline. If it is in shock, 10 ml, because we need to give it very slowly when there is a cardiogenic shock. So maybe we are taking say 15 to 30 minutes while giving the bolus. So as usual with other supportive care, if it is due to MIS-C cardiogenic shock, specific therapy we need to give is steroid, IV methylprednisolone, 10 milligram per kg, 3 to 5 days. Along with that, one dose of 2 gram per kg of IVIG. That's what we need to give, sir.
Okay, thank you, Dr. Vinod. Thank you, Purva sir, actually for a wonderful question. We are already past 8 o'clock. Another speaker is waiting. Maybe, sir, Vinod, I would like to bring 1 or 2 points. Maybe we'll quickly wind up in a minute or so.
Yes,
I was just going to literature. 2 things I wanted to bring up. Basically, there have been studies say that you have a choice of using steroids or IVIG, but there are studies which have already looked at combination. They feel basically giving together is much beneficial. That's how in symptomatic patients you go with combination. That's one aspect. But I also would like to bring it to your attention. Maybe everybody else can also look at that issue. It's like initially we now starting with the methylprednisolone IVIG. The days could come where possibly you're going to manage with the prednisolone actually.
Thank you very much, Karnakar sir. You have raised a good question, which I missed in my presentation, that it is the steroid, which is the mainstay. We can give it in every way. Only question comes is IVIG. As you said, there might be a time where we may not have a IVIG. Even if it is available, affordability is a question. So the government of India has recommended that in case if it is not affordable or not available, then you can go with only steroid, and the studies have proven that even steroid itself has given good results also. So we can consider that only a steroid therapy. In case in a private sector where now litigated minds are more, so because this MIS-C is having both COVID and the Kawasaki phenomena, so we need to give both ideally. So in case it is not available, not affordable, it is always better in a private practice, take a consent that it is IVIG has not given because of non-affordability or non-availability. And then you are safe and you can give only steroids, and that is giving good results also. This is the point I wanted to bring. Take consent if you are not affordable or not available of this IVIG. Okay,
thank you, Dr. Vinod. If there is no questions, so it's already time. Harish sir would like to
May I request Dr. Sanjana Talur to introduce the next speaker, sir? And at the meantime, can you stay back till the end, sir, Dr.
Sir, I will be there, but this thing will be open. Sir.
Sure.
Yeah.
Thank you.
Thank you,
Karnakar sir. Thank you.
Thank you.